The purpose of this episode is to explore common health and well-being strengths and challenges for people with Down syndrome. The content discussed here is not meant as a substitution for direct medical care with relevant professionals. Rather, we hope to share new and little-known information so that families and supporters can be well-informed when accessing medical care. Your child or student's medical or educational professionals may have recommended different practices or procedures that are specific to them. Do not modify or change your child or student's treatment or therapy plan without consulting with your care provider.
Today on the Lowdown, in Down Syndrome podcast, Dr. Robin Friedlander gives us the lowdown on mental health and Down syndrome. Over to you, Hannah and Marilla.
Thanks, Jody. Hi there, and welcome to the LowDOWN podcast. I am your co-host, Marla Folden, an SLP here at the DSRF in Canada. And with me here is my co-host, Hina Mahmood, who is the senior OT at the DSRF. Hi there, Hina.
Hi, Marla. How are you?
I'm doing well. How are you doing?
Good. I'm really looking forward to our topic today. It's been one that you and I have been talking about for a while then that we want to cover. So I'm excited for our guests today.
Oh, yeah. The anticipation has been huge. I've been counting down for this one for several months, so I'm very excited.
Yeah.
Before we continue with our episode, we'd love for our listeners out there to hit that subscribe button and leave a review on whatever platform you're using, and check out our episode pages because we put good stuff there related to each topic that we discuss in our episodes. And you can also follow the DSRF at our website, which is www.dsrf.org. or on Instagram and Twitter by following at DSRF Canada. So today, we will be talking about one of these really intricate areas of health for people with Down syndrome or a dual diagnosis of Down syndrome and autism, and that area is mental health. Just like any other individual, people with Down syndrome can experience mental health challenges, such as anxiety, depression, ADHD.
Yeah, absolutely. And I'm noticing that in increasing amounts with a lot of my clients that dual diagnosis like having the dual diagnosis of autism, but then there's definitely some indications of anxiety and depression as well.
Absolutely. And mental health is a really daunting topic to consider for society as a whole, for sure, and potentially even more so for families in this population. There are some extra challenges when considering mental health in this group of people because of the difficulty that our individuals might have in expressing themselves verbally. And often one of the clearest indicators is in fact a change in behavior from that individual's own normal baseline.
Yeah, absolutely.
And today we're really delighted to be joined in our discussion by Dr. Robin Friedlander.
Yeah, so Dr. Robin Friedlander is a clinical professor and director of the Neurodevelopmental Disorders Program in the Department of Psychiatry at the University of British Columbia here in BC. He also established and heads the BC Children's Hospital Self-Injurious Behavior Clinic. Dr. Friedlander is the past head of neuropsychiatry clinic at Children's Hospital, as well as the previous clinical director of the developmental disability mental health teams in the Lower Mainland. Individuals with a dual diagnosis, so mental health and neurodevelopmental disorders, have historically been marginalized both within the developmental sector and in mental health. And Dr. Friedlander has spent his career working in this very under-recognized area that impacts students with Down syndrome and a dual diagnosis. Dr. Friedlander has published 2 books, 17 peer-reviewed articles, 3 book chapters, and 2 semi-structured interviews. He has also presented at more than 100 conferences across Canada and internationally. Dr. Friedlander, welcome to the LowDOWN podcast.
Thank you.
We're very glad to have you.
Yeah, absolutely. I know that we're very excited. And as a tradition in the LowDOWN podcast, we welcome our guests by asking them 5 secret questions. So they're just little icebreakers so that our audience and Marla and I can also get to know you a little bit better. So are you game for that?
I'm ready.
Awesome. All right. So question number 1, what is your favorite local restaurant? I mean, I know with COVID things have changed a little bit, but what is your go-to place to go?
Well, with the COVID, my favorite restaurant actually is Fet's Whiskey Bar on Commercial Drive, because you can sit outside and it's heated. And I'm kind of a bit nervous about going into restaurant style.
Yeah, absolutely. And so let's say after COVID, when hopefully things go back to normal, where would be the first place you'd like to go for indoor dining?
It seems like so long ago.
Yeah.
But I always loved going to Tamaki. It's a Japanese restaurant on Broadway. I used to live around there in Kitsilano.
Mm-hmm. Mm-hmm. That sounds really good. Yeah.
I think I've been there.
Yeah. It sounds familiar.
It's really good.
Awesome. Hopefully we'll get there sooner rather than later. Fingers crossed. Okay, question number 2. Dr. Friedlander, what are you currently reading? It could be a book. You could talk about a podcast you're listening to.
Sure. I'm reading it's an autobiography by God, I got a blank. What's his first name? Oliver Sacks. He's a neurologist who died a couple of years ago, and he wrote some famous books. Like he was the author of The Awakening Story, which was made into a great movie about these adults with post-encephalitic, essentially catatonic Parkinsonian syndromes, that 20 years after they went into this comatose type state, they ended up getting this treatment and woke up, which is an astonishing story. This is a story. Movie. Yeah, it's a great movie with
Robin Williams, I think.
Robin Williams, who was such a wonderful actor. Yeah. So anyway, this is the story of his life. He's a remarkable man, and if anyone is interested, if you read his books or seen that movie and you want to find out more about him, it's a really good read. He's a very good author. I had no idea. He's not just a doctor who writes. He really is a writer.
Great.
That's rare. There's a lot of doctors who write.
Yeah,
I appreciate their work too, frankly. But it's rare to find someone who can really engage you from a literary perspective and also be a neurologist.
I think it's called On the Move.
Okay.
Yeah.
Great.
Look for that.
That's going to be on my list for sure. Yeah.
Question number 3. Assuming no COVID, where would you love to go for a nice vacation?
Well, my wife and I like to go on hiking trips, and every year we go for a hiking trip in Europe for the last few years, but not this year.
Yeah.
So,
what kind of hikes are you liking?
Well, I must admit our favorite one is we went to France, went to the Burgundy region of France, and we walked through the vineyards, trying out the local produce every couple of kilometers. That was a pretty sweet hike.
That's very nice.
Absolutely.
Yeah.
I've hiked a little bit in that region, and it is not awesome in July and August. Actually, it's really, really hot. But in other times of year, it's gorgeous.
Yeah.
Question number 4. What is your ideal way to cook an egg?
I'm a soft-boiled egg man. And you know what Fetz does, why I like it, is they got this thing called they call it a, I don't know what they call it, but anyway, it's avocado on a scone that's toasted and a soft poached egg on the top and a fantastic sauce. It's really good.
Yeah, it's kind of like an Eggs Benedict kind of situation, but
but without the Benedict, it's not creamy.
Oh, got it. Okay, so no hollandaise.
No.
That sounds really good.
Yeah,
great.
I know. I kind of want to go there now. Last question from our icebreaker questions is: do you have a de-stress routine that's your go-to after a day of work?
Well, this is what I do. And I tell all my patients to do it as well. But of course, patients never listen to their doctor, so I don't know if they ever do anything. But I need to run. So if I don't run, I play tennis. I do one of them every day. Mm-hmm. And that's how I deal with the kind of accumulated stress of the day. Mm-hmm. And can highly recommend it. Although I must admit, I say the terrible threes at this time of the year. It's dark, cold, and wet.
Yeah.
So in previous days, I'd go and work out in the gym after work, but not in the COVID times.
Yeah.
No.
Exactly. Yeah. I think that physical activity is just so much more important nowadays too. Even if it is dark, I'll go for walks, but I see people running. They'll have their gear on with their headlamps and they'll make it work. Yeah.
Mm-hmm. Great.
Oh, yeah.
Absolutely. Okay. Well, let's dive into our topic for today, which is this mental health overlap with the people that we care about so much, which is people with Down syndrome and dual diagnoses. The first area that we wanted to chat with you about today is this broader overlap of either individuals with a single diagnosis of Down syndrome or a dual diagnosis of Down syndrome and autism, and then mental health on top of that. So when a person has Down syndrome, is your consideration of their mental health any different than the other clients you see?
Well, so I should just preface this by saying that I see both. I used to see all ages, and nowadays I only see children, and some young adults who I saw in childhood, and there's no one really to follow them right now. So, so mainly my experiences with children right now. But I can tell you that I don't see a lot of kids with Down syndrome compared to how many kids with Down syndrome are out there in the general population.
Okay.
And I think there are studies showing that any child or adult who has a neurodevelopmental disorder like Down is at increased risk of mental health problems. But interestingly enough, if you have Down syndrome, your risk is overall less than if you have a developmental disorder due to, say, another genetic syndrome.
Right. Mm-hmm. That is really interesting.
Yeah.
So let's speculate a little bit here. We're not doing research live, but do you have any thoughts as to why that population trend exists?
Well, I had a colleague of mine in Boston, Joni Beasley, and she had a sister with Down syndrome. And I remember she said, Down syndrome is the royalty of developmental disabilities. And she said, so the reason is, firstly, that as a rule, people with Down syndrome seem to be supremely confident and often have wonderful, very likable social skills. I'm talking in general now.
Yes.
And I think the other reason is that, and you have to decide if you want to edit this out of your podcast, but if someone's got Down syndrome, they got Down syndrome. It's not something that the parents did. They weren't drinking in pregnancy. The child didn't fall on his head. People tend to blame. And I think the Down syndrome parents kind of know they got it honestly.
I see what you're saying. So there's maybe less guilt overall in those families. Less
guilt and less blame.
Right. Okay. I see. Now, if somebody has already a dual diagnosis of Down syndrome and autism, and then they come to you, do you approach mental health differently in that capacity? Because clinically, Hannah and I work with a large number of students, and I would say about 50% of my caseload has a dual diagnosis of Down syndrome and autism. So it's not unusual that we would have students that already have two, and we're considering more diagnoses.
Right. So just to clarify, you're talking about a population of youngsters who have Down syndrome and another group who have Down syndrome and autism. Is that what you're referring to?
Yeah. So I'm wondering if you look at it any differently when there's a group of students who just have Down syndrome and it's very clear that there's autism is not in the mix.
Right.
And then the other sort of group where there's Down syndrome and there's autism, and it's very clear that we have two things going on at least.
Right. Okay. So, I mean, the way I would look at it is that if you're born with Down syndrome, you almost certainly have a intellectual disability, which is usually in the moderate intellectual disability range. Mm-hmm. You are more at risk for two neurodevelopmental syndromes. The one is ADHD, which is very common and may occur in up to 50% of children with Down syndrome. And the second, which is less common, is autism, which I'm not sure what the latest figures are, but I thought it was around 10% of children with autism.
12. Yeah.
Percent of children with Downs are prone to get autism as well. So, yeah, I mean, obviously, if you're dealing with Down syndrome and an intellectual disability, and as a speech and language pathologist, Molly, you'll know that these kids often have a difficulty being understood because they have some kind of dysarthria, and so it can be very frustrating for someone who's social and actually has the words but can't be understood. Yeah. So I can see lots of reasons why these children would be at risk of being very frustrated. So the way I see it is, the child has ADHD or autism in addition to Down, and that the child and this difficulty expressing themselves, and that's going to present in the first 5 years of life.
Yes.
And so these children would be more prone to getting frustrated and having sleep problems. So in the first 5 years of life, and I should let you know that I don't tend to treat the very young kids myself, but in the first 5 years of life, that would be where you'd want to be helping them, is with communication and dealing with frustration and sleep.
So what you're speaking to here is both the need for early intervention, which is well documented, and we hope always that little kids with Down syndrome and or dual diagnosis are getting access to early intervention, and a lot of it. And the second thing, which is that sleep assessment and relevant sleep treatment, which is already recommended for all students when they reach the age of 4. It doesn't necessarily happen that way. We advocate for that a lot. Mm-hmm. But this is yet another reason to be doing both of those things. I want to talk a little bit about anxiety and depression and some of the other mood-related disorders. Are there any kinds of mood disorders that are more likely for people with Down syndrome? And on the flip side, are there any things that are less likely?
So when it comes to mood disorders, and by mood disorders, we're generally talking about someone who's clinically depressed. Mm-hmm. So they have depression, they feel depressed, they're sad or irritable, they have accompanying problems with their sleep and appetite and motivation. They may feel that life isn't worth living, there's social withdrawal. That's what clinical depression is.
Yep.
Or the flip side, which is mania, mm-hmm. where you feel maybe euphoric, where you're laughing too much and you don't need to sleep because you've got so much energy.
Yeah.
And you might have problems with your ideas just flipping from one to another. You might be somewhat grandiose, believing you can do things that you really can't do. Mm-hmm. I mean, it could be as subtle or simple as believing you can drive a car when you can't. Mm-hmm. But your peers maybe are starting to, your 16-year-old sibling is getting a driver's license, and I can't remember what the age is now, but I think it's 16.
Yeah.
And why can't you? And you might develop some grandiosity thinking you can do that. So that's an example of, so that's a manic syndrome. Mm-hmm. So so firstly, it's very unusual to get mania or depression before puberty. If one depression is probably a little more common in Down syndrome than in the general population, and does increase, the risk increases as the youth gets older. Mm-hmm. Mania, which is part of a so-called bipolar mood disorder, mm-hmm. is a very interesting question as to whether it is less common in Down syndrome or not. When I started out in this, working in the field of developmental disabilities, which is a long time ago, there was a psychiatrist called Robert Sovner in Massachusetts who had this theory, because he wasn't sure why he was seeing a lot of patients with Downs who had major depression, mm-hmm. and he wasn't seeing any with bipolar mania. So his theory was that either it was less common, mania, or people with Down syndrome had a more attenuated form of bipolar. In other words, the symptoms of bipolar were they were there, but they were more subtle and not as striking as one would normally see in the general population. Mm-hmm. And I think that's my clinical experience, is that if one has Down syndrome, the symptoms of mania are more attenuated, are milder, but mm-hmm. it does still occur.
Hypomania.
It would look like hypomania, yeah. Mm-hmm. Yeah.
So, okay, there's a lot there that I want to unpack for the people that are listening. The first thing I want to address is, what should parents look for? Let's talk about depression first. What are we looking for? You've mentioned disturbances with sleep. Are these the classical symptoms of depression that we would see across the general population as well? Appetite, sleep, irritability, low mood, same kind of things?
Mm-hmm. Right. So if one has Down syndrome, I'm thinking of the very first adolescent I saw. Actually, she might have been even a young woman by then, who had Down syndrome and depression, and she literally couldn't move. She was like stuck
Catatonia.
Mm-hmm. Well, she wasn't quite catatonic, but she was almost catatonic. She was mm-hmm. in her bedroom, didn't want to get up. The lights were out. She was sleeping all the time. She had zero energy. She wasn't eating at all. And I remember being really quite shocked because she wasn't getting any help.
Yeah.
So to answer your question, one has to infer. She also wasn't speaking. Oh, that's the other thing. She lost skills.
Yes.
She suddenly couldn't control her urine.
Oh, yeah.
Which she'd always been able to do for as long, for many years. So she'd actually lost skills and regressed and was hardly speaking. So in this case, I can't ask her how you're feeling because she can't tell me. Mm-hmm. But so I'd had to interview her caregivers. Mm-hmm. I can't recall if she lived at home or not, but I had to interview her caregivers and ask them, is she crying? And they said yes. I say, does she ever laugh? No. Did she used to laugh? Oh yes, she was a happy young woman. Until about a year ago, she used to laugh all the time. Does she? And then the other critical question one has to ask for depression is, because the two key questions one asks for depression are you tearful, crying, or irritable? And the second one is, have you lost interest in things that you used to do? We call it anhedonia. There's just a lack of pleasure in the things that gave our life pleasure and meaning before. Mm-hmm. And they say, oh, yeah, she used to love to go dancing and she used to sing all the time. And she used to love to go skating and love to see her friends. And she stopped all those activities over the past year. Yeah. So, yes, she's got the symptoms, but one has to get the information from someone who knows her well.
Mm-hmm. So I think the point that you're making here is, if someone's listening to this and what they're hearing describes their child's baseline, then we're not as concerned. I mean, I'm still concerned if someone's in their bed all day. Don't get me wrong. Yeah. But everybody's coming from a different baseline. So if your baseline is very social and you're dancing and you're singing and you're engaged with other people out of the house, and then over a period of weeks to months, that's disappearing, you're losing functional skills, then certainly we become very concerned at that point, and they should talk to somebody. This sounds to me like exactly what I was going to ask you in my next question, which is that we occasionally see a client who has a major depressive episode like this, where they have lost a number of functional skills, huge decline in their communication, and often a big retreat from their regular life, and even fundamental skills, self-feeding, toileting, some of these kind of things. It's rare. I don't want to panic families. This is not happening to everybody. Can you talk a little bit about what can set that in motion? What's happening there that causes this sort of major decline in function?
Very sudden too. Yeah.
Mm-hmm.
Well, I don't think we understand what causes these major changes in the regular population.
Fair enough.
We just know that if one has serious clinical depression, it doesn't just affect how you feel in your emotions, it also causes your body to slow down. You get what are called changes in your hypothalamic functions, which is the hypothalamus is the part of the brain that controls eating and sleeping and sexual activity and energy, and it just slows down. That's part of one of the so-called biological characteristics of a severe depression.
Okay. So in other words, we don't necessarily know why, but we know that depression goes beyond just how you feel about things around you. Okay.
Yeah, I think that's right. In other words, we're saying that there's such a thing as depression as a feeling that most of us experience at some point in our lives where we feel sad, versus depression as an illness. And what we're talking about now is depression as an illness.
Right. Okay.
Yeah. Where it's affecting your full daily functioning. It is, definitely. Do you feel like, Dr. Friedlander, that sometimes we can connect this major depressive episode to perhaps a traumatic event, or what could be perceived as a traumatic event by our individuals with Down syndrome? Like it could be the littlest thing that could have cascade effect at all?
Well, this is the $1 million question nowadays. I think there's a belief out there, which is often with good reason, that traumatic events, and we know that if you have adverse childhood events growing up, you are at more risk of mental illness like major depression as you get older. But I can tell you, I also see folk who have a major depressive illness that is not related to traumatic events, and that's probably more common.
Okay. Okay, that's good to know. In clinic, sort of anecdotally, we notice, because we see students from age pre-birth to about 25 on average. We see some older adults, but that's a little bit more unusual. We notice anecdotally that there's periods in a student's life where things like depression and anxiety tend to crop up, is the way to put it. This could be either the early school years, or when we transition to high school, or the most common one is high school is done. And what next? Can you kind of speak to these sort of sensitive periods? What's happening? Is it the environment that's making this to be more likely? Or is this a brain development thing going on? What are your thoughts on that?
So when it comes to periods of transition, maybe I can talk about the last transition, which is maybe the high school period and then into leaving high school. I think that's probably the most difficult time for the youth with Down syndrome that I have worked with. And the reason is because I think the other students who may have connected with them and been friends with them when they were younger start to find they have their own lives. They get boyfriends, they get girlfriends, they get their own friends, and their parents aren't making arrangements for them anymore. And the Down syndrome adolescent is more likely to feel alone and quite lonely. And I think it's quite well described that during this time, Down syndrome youth are more likely to become more socially withdrawn. Now, I don't really understand it, but I suspect it's a reaction to basically not having friends and connections. I think that the youth who are involved in groups like Special Olympics and community activities do better, but I think that's the developmental problem there. And of course, once they finish school and they lose that security and connection, I think it's really hard.
And I think, we can't underestimate that it is a hard time for every adolescent when they transition to do something else. But one of the major differences is that for a typically developing adolescent, there usually is a something else, and a something next that they have either planned or been pushed into by their parents or whatever. But something's coming after this. And a lot of times for our students, there is nothing that takes up that much time, that there's such a routine around it that involves interaction with people every day. And we see it a lot where students really suffer in that time. And certainly what you've just described is a huge argument for having peers and supporting friendships with other people with Down syndrome and developmental disabilities. Even if your child is doing a great job at having typically developing peers, we still want them to have peers that have developmental disabilities.
Right.
Sure.
Right. And I would say that I don't see this as illness. I think this is a developmental, it's part of the potential developmental trajectory of Down. And I agree with you. This is the solution, is to try and really have enriched connections developing, and with other kids with special needs as well as they get older.
And kind of having that in place before their high school years end. Because I know as an OT and Marla's an SLP, a lot of our conversations for some of our older teenagers with the parents begin at the beginning of their last year of high school. So it's like, okay, like when they're 16, let's start talking about what is life going to look like after high school. What supports, and there are lots of supports that need to be in place and lots of funding that needs to be in place. So I think that's a really important point as well, is that those conversations need to be had earlier and not wait till the last year of high school.
Absolutely.
Can I say something? Just going back to the major depression. I mentioned that the depression can look like an illness. It's because it's so severe. I just wanted to, you're probably going to ask me this, but I do want to reinforce that youngsters and adults with Down syndrome are more prone to having an underactive thyroid, and that if you have an underactive thyroid, it can look like some of these features of depression. That's something that should be checked on an annual basis if you have Down, which your pediatrician generally would do.
Glad you mentioned that. Yeah,
I am too. Yeah, and I think it's supposed to be a very regular assessment, 6 months or every year, one or the other of those, and it's a blood test, fairly straightforward, but important, absolutely. And clinically, we see students that are hypothyroid and also hyperthyroid. So it's worth checking because you don't necessarily know which thing might be going on. Let's talk a little bit about anxiety for students with Down syndrome. Certainly, I see students who have social anxiety and this tends to be the students who are more aware. So they might be higher functioning, if we want to call it that, from an intellectual perspective. Right? They're not as far behind their peers, but this also, catch-22 makes them more aware of the differences between themselves and their peers. And what this might look like from my perspective is I'm perfectly capable of talking, but I'm not going to talk to anybody.
Yeah.
Do you have thoughts on anxiety in the population of people with Down syndrome?
Well, as you're asking the question, I'm thinking clinically, I don't see anxious kids with Down syndrome. I mean, it's not that they're not there. They don't come to see a psychiatrist. They're probably seen by their pediatrician and by you guys in Down Syndrome Research Foundation and by the school. They don't tend to come to me. But I mean, I think the important thing about anxiety is it can happen at any age. And once again, I think you at the beginning, you talked about the whole concept of baseline exaggeration. So this implies that I think you said it really nicely, but I'll say it again. If at your baseline, you're pretty happy and you're outgoing and you have no problem talking to people, and suddenly you want to, you keep quiet when you're in public and you don't want to talk to anyone, one has to wonder if you then acquired some mental health problem. And so the two possibilities are some kind of generalized or social anxiety, or what Marla may have been thinking about earlier, which is a form of selective mutism.
Yes. That is exactly what I was thinking of. And I see it more often, I guess, than you would think, where a student will have their preferred people to talk to that they feel comfortable with, and then will either, sort of act like they cannot talk or just will not talk with almost anybody else. When it does happen. And I want our listeners to, if that is your experience, there is help for that and there are strategies for that. And you should talk to at least your SLP and probably get a psych to help you as well.
Right. No, I think that's important, just because I think, selective mutism is treatable, as Marla said. They're actually quite effective behavioral treatments for selective mutism. And but you need to have someone who knows what they're treating. It's just a regular counselor may not have the skills.
Right. And anxiety, I think it's Anxiety BC. I'll put the link on this episode page. Or it's Anxiety Canada, maybe, has some really great info that you could pass to your child's team members to sort of get the ball rolling if that is happening with you. The next thing I wanted to ask you...
I just had a quick question. Dr. Friedlander, you were mentioning earlier that you don't necessarily see a lot of patients or clients with Down syndrome that have like a co-occurring anxiety. Would you attribute that to the fact that anxiety can manifest differently for our individuals with Down syndrome? Because I know that it's not always an outward physical manifestation. So what are your thoughts on how anxiety can manifest? Because I've had this conversation with parents who outwardly will say, no, he or she is not anxious, but they might be experiencing it in a completely different way.
Okay. So maybe I can answer that in a couple of ways. The one is that in general, typical children, if you ask the parents, are you concerned about your child? Parents are really good at describing if a child has disruptive behavior. Many parents, not all, are not as good at being aware of the child's internal feelings, states.
Yeah.
I mean, some parents obviously are, but feeling states that are internal are much more difficult to access because the kids don't tend to talk about it that much. So in general, these anxiety symptoms are something that family, school may not be aware of. Then in terms of coming to me, I can tell you this is just the way my referral pattern. I tend to get disruptive kids. So if the kid is aggressive and they're not getting better, someone says they better see a psychiatrist. That's how they get to me. A kid who is more quiet and withdrawn tends not to get referred to psychiatrists. So it's really for parents and teachers and support team to be more sensitive and aware of this possibility. How does one check if a child has anxiety? Well, you can infer it from their behavior. If they're more socially withdrawn, if they're not speaking, if they kind of sleeping.
I was just going to say sleep difficulties, not sleeping.
If they're having insomnia, if they're tired, if they have muscle aches and pains, general pains in their body that are unexplained, tummy aches and headaches on school days, wanting to sleep in their parents' bed when they have been sleeping in their own bed before this. So you can infer it from their behavior. And you can also ask the kid, I usually ask children or adults a multiple choice question. I find that the best. I'll say, if I ask an open question like, how are you feeling? They'll say, good. Yeah, right. Yeah. So I say, are you feeling, do you have worries? And then they may not know what worries are. So you may have to ask in different ways. Do you get nervous? Do you get frightened? You may then have to ask more specific questions like, do you sometimes feel funny feelings in your tummy, like butterflies in your tummy? Do you sometimes feel your heart beating really fast? Do you have problems with your breathing? And then the multiple choice. So those are multiple choice questions. Those are fairly leading questions. But the multiple choice question may be, do you worry about the future is a good one. Do you worry about your parents? Do you worry about school? Do you worry about friends? Do you worry about bad things happening?
Yeah.
So actually, as I'm telling you that, I'm just realizing none of those are multiple choice questions, because actually for anxiety, it's like, what's the opposite of anxiety? Everybody has a bit of anxiety. It's easier, just as I'm talking, to try and tap someone's mood. So ask, are you feeling sad? And the patient says no. And I say, are you feeling happy? And they'll say no. So I'll say, well, are you more happy or more sad? And then just in case they're going to try and please me or give me my last, if I said sad, they're going to say sad, then I have to ask it the other way. Well, are you more sad or happy? Just to make sure I'm getting a reliable answer. But actually for anxiety, it's hard to ask a multiple choice question.
Oh, yeah, you're right. And I actually spend a lot of time on emotional literacy and vocabulary for this exact reason. Our students tend to not be comfortable with negative or what they perceive as negative emotions. And sometimes they even seem like they think they're going to get in trouble if they're not happy. So the go-to is always, I'm happy. And that is not an answer that we can necessarily trust. So we'll put some information on our episode page for how to sort of get into this a bit more. But
Marla, I mean, I think it's such an important skill to be able to identify emotions and label them. At one point I was, like sometimes I'll ask the child, because I can see they're getting upset in the office. And I say, what's happening inside? They are unable to identify the internal feeling state.
Yeah.
Yes. Yeah.
And sometimes we have to give them the vocabulary to be able to say, I'm frustrated. I'm not happy or something. And And I think that's such an important role for educators and families and you guys.
Mm-hmm. Yeah. And sometimes we'll even use a prop, like a doll or a picture of a person, and talk about, where do you feel it? Where are you feeling it right now? Yeah. Or, when I'm happy, I feel it here or there. When I'm worried, I feel it in my tummy or my head hurts, something like that. But making it very visual for our students.
And also acceptable. Like, it's okay to feel those things, right? Like, you have space for all sorts of emotions. So if we're working on like the zones of regulation program, all my feelings are okay. It's just, understanding what to do when you're in each of the different areas. So
my working hypothesis as to how this not acknowledging bad feelings gets started and happened is these feelings are accompanied with a lot of externalizing behaviors when kids are little. They don't have a way to say it, so they're going to show you with their body. When they get frustrated, they're going to hit you, they're going to push you, they're going to run away. Exactly. And they get in trouble for that. Yeah. And so right there, we're learning, can't have those feelings, not going to acknowledge that those exist, rather than working on a more acceptable replacement for some of those,
especially if you have communication difficulties too, right? Then you can't express it. Yeah,
exactly. Exactly. All right. If a student, let's say we start elementary school and it's rocky, we have a lot of externalizing behaviors, we're running away, things are happening. Is it more likely that that student who had a hard time with their externalizing behaviors in elementary, and for people listening, I just mean acting out, are we going to see internalizing mood issues? Is that more likely when they get older? Or is it kind of luck of the draw? You might get one, you might get the other. I'm trying to figure out if families should be preparing and predicting, or if it's going to be random.
Okay. So the number one cause of children being disruptive, in other words, difficulty waiting, easily getting frustrated, interrupting, getting in people's space, perhaps escalating to aggression or self-injury. I'd say probably a couple of causes, but I'd say the top two causes are the child isn't sleeping at night properly, which is why I said you want to address sleep, or the child has ADHD. And the reason I mention these is because they are highly treatable. And I can tell you that it's very difficult for families because all kids are challenging. I've had kids, I can tell you. And my children would tell you that I was certainly lacking in many parenting skills, despite my best efforts. They're hard work, having kids.
Yeah.
And sometimes you get angry and you lose your temper and you don't know how to manage it. So I personally think that every parent should have, like in the first 5 years of, probably the first 3 years of life, they should have some parent behavioral management training. And there are some really good courses that do this. For example, the Canadian Mental Health offer a program where they actually provide some telephonic advice to families about how to parent their children in terms of behavioral problems. So now in terms of a child who has special needs like Downs, there are some other programs. I'm not sure if the Canadian Mental Health program would see a family with a child with Downs. It's a good question. But
we definitely have a great in-house expert too at the DSRF with the positive behavior strategies of Dr. Susan Fawcett. So but I think that's a really good point though, because those skill set needs to be in place for sure.
So anyway, to answer your question, I think all parents should have some kind of general strategies for managing children's behavior so that we're able to effectively provide the children with structure and get them to listen to important things they got to do and learn without us getting rattled and angry, because that's not good for the kids and it's not good for us.
Right.
So that's the first thing. If a kid gets into school, I think once they get to grade 1 and they are having disruptive behavior and it's not improving, and you've done the parent behavioral management training, and the child has symptoms of ADHD, I do think you should see your pediatrician and see if they do have ADHD and consider treatment for that, because some of the medications can be highly effective.
Mm-hmm.
I remember one of the families that I first, this is years ago, whose son had ADHD. He was about 7, and this kid was hell on wheels. He didn't stop, and the mom was really embarrassed because she said all the other Down syndrome kids are so good. And the other mothers, they look at me and I feel they're judging me as not being a good parent.
Yeah.
And this kid did have significant ADHD, and it was treatable. So just be aware of that.
Mm-hmm. Absolutely. I'm so glad you brought that up, because we do see it. And, we are not psychiatrists, so we cannot make that diagnosis, but we can see a really clear difference, and it's not necessarily in parenting styles, between some children who can sit and do a table task and attend, and we can do our 45 minutes, it's great, and other students where we are running, we are moving, and we are not stopping, and it doesn't change. We expect the little tots to be busy. 2, 3 years old, we expect that. 7 years old, we hope that we've progressed past that.
Mm-hmm.
Yeah.
Yeah. So, and of course, just to be clear, these neurodevelopmental disorders tend to occur together. Mm-hmm. So if you've got, say, Down syndrome and autism, it's quite likely you got ADHD as well. It's not like one or the other.
Mm-hmm.
Thank you for saying that as well.
Exactly.
Yes.
Yeah. Yes. Yeah. The co-occurrences, definitely. Yeah. So actually, this forays us into our next area beautifully. So let's talk about treatment. Now, the two commonly used approaches are medication and...
Hannah.
Oh,
yes.
Sorry, Hannah, can I say one thing?
Yes, of course.
Before we talk about treatment, I just wanted to make sure that we at some point talk about catatonia.
Sure. Let's do it. Go for it.
I think, you brought it up with that young woman I mentioned earlier who had that severe depression and lost skills. Mm-hmm. So this is just a really interesting syndrome that seems to be unique to children with autism and children with Down syndrome. Mm-hmm. And somewhere around about the age of 8, 9, 10 years or a little older, the kid starts losing skills. Looking back, I'm just wondering if that, because I wasn't really aware of catatonia 20 years ago, it's possible that young woman who had the major depression did have some catatonic features. But what's classic about the catatonia is that the child starts developing some fairly classic symptoms. They slow down and they suddenly stop and freeze. Mm-hmm. They become prompt dependent. So these are children who literally stop with their fork, the food's on the fork when they're eating, and it stops between the plate and the mouth. And the parent has to say, okay, put the food in your mouth. And they do. Mm-hmm. And then they have to be told, okay, put the fork on the plate. That dramatic. Or it might be they just freeze for half an hour, don't move.
Yeah.
Or they might acquire some weird posture and hold it for a while. Or they might have some unusual movements of their hands, like a little flap or some odd postures. Accompanying this, the child may stop eating and stop speaking. And it can look like depression, actually. It can also look like the child suddenly became autistic. And I'm thinking now of one young woman who developed these features at the age of 12, and she was diagnosed with autism. She had Down syndrome, but at the age of 12, she had all these unusual features, and she was diagnosed with autism. Now, autism doesn't start at the age of 12. Autism is there it's pretty evident within the first few years of life. You don't suddenly get autism at 12. But her features were consistent with autism, and someone gave her the diagnosis. But when these symptoms became really severe over the next couple of years, she ended up seeing me, and we were able to treat it quite successfully. So she had catatonia, and which I just wanted to bring it up because it's a really good story. About, I don't know, maybe 20 years ago, I wrote a paper with some colleagues of mine, Rob Parry and I can't remember the other author, Laurie somebody, and it was called Obsessive Slowness in Down Syndrome.
I've read that paper. Yeah.
We thought this was a form of OCD, presenting as everything slowed down. But looking back, once I became aware of the phenomenon of catatonia, I realized we were wrong. This was not a form of OCD. This was catatonia. And I'm interested in while I read the paper because you probably saw none of the patients got any better. Because we were trying to treat them with drugs used for OCD, which didn't work.
Yeah.
So
I'm really glad you brought this up. What you're describing applies to 3 of the students that I either have now on my caseload or have had in the past. And it's absolutely devastating for a family to watch this happening and not know why. And it is very heartening to know that it can be treated. Is it treated primarily with a drug for mood?
Nope.
Opposed to OCD?
No.
Guessing. What do you do?
So I'll tell you what you do. All right. The first thing you do is you send them they should see a neurologist.
Okay.
You want to make sure they don't have something weird going on in their brain. None of the cases that I've treated had anything weird going on, but there are some weird things that can happen. They should have a neurological assessment. Assuming that that's all normal, we treat them with high dose lorazepam, which is a benzodiazepine used for anxiety. So the treatment is interesting because the treatment's either lorazepam. Well, actually, all the cases that I've treated with lorazepam. And I'd say the response rate is probably about 70%. So they don't all get better, but most of them do. Yeah.
That's impressive. And that's really good information to know. I will be making some referrals soon.
Yeah.
Yeah. That's really good because it's a bit of a mystery, and you just the sudden sort of inability to initiate a movement like you're describing is alarming. Absolutely.
Yeah. And these families are like, they're so happy when they get their kids back.
Yeah, absolutely.
Yeah.
Yeah. So thank you for mentioning that, because I think and there is definitely more research happening now with regards to catatonia and Down syndrome. And I think at this year's Down syndrome medical interest group conference, they had a special presentation on catatonia because it is becoming more recognized as something that needs to be looked at. So so let's talk a little bit about treatment. And the 2 commonly used approaches are generally medication and CBT, which is cognitive behavioral therapy. And for those who may not be aware, CBT is a treatment approach that focuses on how our thoughts can affect our behaviors. We've all heard that medications for, things such as ADHD can be vastly overprescribed. And we've heard, Marla and I both have heard horror stories from parents about going on ADHD trial medication and they just don't recognize who their kid is the next day. And I think this puts families in a position of hesitancy and caution, which is, definitely not a bad thing. They should definitely be hesitant and cautious. Can you speak about whether medications for things like ADHD and anxieties and depression work for people with Down syndrome? And should this be done simultaneously with CBT, or should one go first?
Okay. So the answer is that in general, it partly depends on the severity of the case. Mm-hmm. I think if a child has fairly severe symptoms, I would probably go to medication sooner than later. So I'll give an example. If you have anxiety, generally the treatment for anxiety is CBT, cognitive behavioral therapy, which you described. Mm-hmm. Cognitive behavioral therapy can be modified for children with Down syndrome. And so just to be aware, cognitive behavioral therapy says that the theory is that our thoughts affect how we feel inside. If you can stop having scary thoughts and stop maybe catastrophizing them, for example, so that you worry that something bad's going to happen and suddenly you worry that the whole world's going to end and you're going to die. If you can stop those catastrophic thoughts, then one can ameliorate the anxiety, the underlying feeling of uncomfortable feeling of anxiety. The idea about modified CBT. So that's CBT. So the idea is that you change your cognitions or your thoughts, and then you change your behavior. You can't do one without the other. If you just change your thinking, but you don't change your behavior, nothing will change. It's a bit like the whole theory that, the whole old story that if you fall off a horse, you got to get back on the horse. Otherwise, it'll be harder to get back on that horse. So if you fall off a horse, you should try and get back on as soon as possible, or you get more and more anxious about getting back on that horse. Mm-hmm. So dealing with anxiety is not just changing your cognitions, but also changing your behavior. The idea about modified CBT is that you focus more on the behavior, and less on the cognitive part of it. Mm-hmm. So, for example, let's take the horse example. You fall off the horse, and then you don't want to get back on a horse again. You may want to spend less time thinking about why you're having irrational thoughts and catastrophizing about what could go wrong getting back on the horse, mm-hmm. and maybe more time starting to behaviorally desensitize to that. For example, maybe just looking at a picture of a horse and practicing a relaxation exercise at the same time, and then maybe visiting the farm where the horse is, but not getting on the horse, and slowly getting your confidence up. Mm-hmm. So that would be an example of what's called behavioral desensitization. Mm-hmm. And so small c, big BT is a good treatment for anxiety. Mm-hmm. And I still think that's a good idea. Mm-hmm. If the anxiety is disabling, the person doesn't want to go to school because they're terrified of leaving their mother, because they've got severe separation anxiety, and some behavioral desensitization is not working, I wouldn't wait 6 months. I would try and treat that child with an anti-anxiety medication. And we usually start with medications called serotonin reuptake inhibitors, mm-hmm. such as fluoxetine or sertraline, one of those medications, sooner than later. With regard to the whole question of medication side effects, and I think Marla and you brought up the whole issue of families having horror stories of children having really bad effects from medications. Mm-hmm. Look, medications can have benefits and risks. There's no medication that doesn't have a potential side effect. And so if you go on a medication, it really needs to be carefully monitored. So just talking about the anti-anxiety meds, because I was talking about that, these medications don't work straight away. They often take 2 or 3 weeks to start working. Mm-hmm. You want to build the dose up, starting at a low dose, but increasing up to a so-called therapeutic dose. Mm-hmm. The commonest side effects of so-called the serotonin reuptake inhibitors in childhood are that the child becomes activated. and it's not often well known, that children who go on these medications are at a much higher risk of the so-called behavioral activation than adults, and may not be able to describe it. Even typical kids may not be able to describe it, but it tends to present as the child feels uncomfortable inside. They get a sort of inner sense of restlessness. They may start to pace. There might be problems with sleep, and they may be irritable. Yeah. So this is obviously not a desired effect. It's a side effect. The way to avoid it is to start with a really low dose. I mean, obviously, if someone has this kind of side effect at the lowest possible dose, then they can't take that medication. Yeah. It's just, you have to look at something else. Yeah. But in general, if you start slowly, you can try and prevent that these side effects, that so-called behavioral activation that you get with these anti-anxiety meds. Mm-hmm. Do you want me to talk about ADHD side effects? Or
yes, please. That's exactly where I was going to go. So please go for it. Yeah.
Okay. Yeah. So with regard to ADHD meds, in general, children with not just Down syndrome, any children with special needs, including autistic kids, don't do as well on the so-called stimulant medications that are the first-line treatment for ADHD as the general population. Now, that's not a reason not to use them. They can still be very effective. And in fact, they are sometimes the most effective medications for these kids. But just to be aware, what's the target symptom? What's the target symptoms for the ADHD meds? You're really looking at helping the child to sit at their desk or in circle at school, not kind of getting in the other kids' space and touching them and bothering them, because that's really going to affect the kids' ability to make friends. Being able to wait in line, being able to sit at the table at night, not bother their parents when they're on the phone too much, being able to manage their frustration. So if this is really what you want to help. Yeah. So start with a stimulant. The most common stimulants are based on a medication called methylphenidate or Ritalin. My experience is if you give too low a dose, it doesn't work. If you give too high a dose, you can get irritability, or the kid can look like a zombie. They look like they're spaced out. So obviously, the way to avoid that is by starting low and increasing the dose slowly. The good thing about stimulants is that the day you give it, it either works or doesn't work.
Yeah.
If it's not working and there are no side effects, increase the dose. Yeah. Until you get to a therapeutic dose. But what I just reiterate, kids with Downs may not do as well or respond as well as typical kids to medications like Ritalin. And in that case, I tend to use an alternative medication. There are two options. The one that I like the most is a medication called clonidine. I think that's a really effective med in about 2/3 of kids. The problem with clonidine, you have to give it 2 or 3 times a day, usually 3 times a day, which is a bit of a pain. Yeah. But it tends to be effective. Some kids can't tolerate it because it can make them drowsy. So the point is there's no perfect medication, but really you need to be working closely with your primary physician around this. And the bottom line is start low, but if there's no response and no side effects, slowly increase the dose until you get to a therapeutic effect.
That's great. I have a whole bunch of other questions. I'm going to try to get myself back on track for a second. So with respect to CBT, and thank you for kind of alluding to that we can adapt CBT. That's really great. For Marla and I, we see a wide range of clients at the DSREF. Some are very chatty, some are minimally verbal, or some are nonverbal altogether. So you kind of covered how we can adapt CBT to different cognitive levels a little bit, but how effective could CBT be for some of our students with varying language levels? And Marla, please feel free to jump in if you want to.
Nope, you nailed it. Yeah. You nailed it.
Perfect.
Well, my sense, Heen, is that you probably know the answer to this better than I do. Do you want to tell us what you think? What you guys use for children who have minimal verbal skills?
Marla, why don't I let you go first as the SLP? Yeah.
Just because a child doesn't express anything verbally or minimally verbally or through their AAC device, etc., does not necessarily mean that they don't understand you. Those two are not on par with each other. So it doesn't mean you don't talk at all, but you do adjust the complexity of your language and what you're going to say to the student when you're describing things like fear and particular stressful situations, whatever is relevant. And I would rely more on visuals and props to illustrate what I'm talking about, just to ensure that I'm providing the student multiple ways to understand what I'm talking about. And the focus would be on the B, on what are we going to do to replace this behavior. And we would use a lot of sort of contingencies where when we see what we are going for, our target behavior, we're going to get very happy and very excited about that. Yeah. And, if we're seeing things that we don't necessarily love as much in the classroom, some of the disruptive things that Dr. Friedlander was talking about, we decide, are we ignoring it? Are we removing the child from that situation to keep everybody safe, etc.? But we pay contingent attention to what we are sort of targeting as a behavior.
Yeah. And I think behavior is a little bit easier for them to understand than thoughts. And I think both of you alluded to this earlier that, emotions are a tricky thing to understand, how your thoughts affect your behavior. So I think having that emphasis on behavior and the output and the externalization of their thoughts is a little more salient to them, and they can understand it more and relate to it more. So I think that's from our perspective. Yeah. And using their interests, right? So visuals, things that are more meaningful to them in their lives, using those as examples can also be really helpful. Okay, great. That was a nice little brainstorming session. I love that. So Dr. Friedlander, in terms of medication, so I've had multiple conversations with parents who I know I've had some clients that have a dual diagnosis of Down syndrome and autism, and ADHD is in the mix somehow. I've had some parents that have been willing to try medication, but say after maybe a week or so, nope, it's not working. My kid is acting differently. So what I normally say, not being a psychiatrist, and very cautiously, I say, well, talk to your doctor about maybe trying a different medication or giving it some time. So what is your advice to parents that are really just having a hard time waiting out that 2 to 3 week period to see a change after medication?
Yeah. Well, let me just first preface this by saying that most of the community medication management for children with Downs would be done by their pediatricians. And pediatricians generally do fantastic work, and they often are the one dependable professional in the child's life from the beginning. But let's be quite frank, most pediatricians have almost no psychiatric training. It's remarkable how well they do. And some of them do fantastic jobs. If you feel that the family feels they're just not on top of it, they should speak to their pediatrician, and if necessary, ask for a referral to a psychiatrist. I don't know if people are afraid of psychiatrists. There still is some fear of the. I'm not sure why we're so scary, but
you can blame movies for that. I think.
Yeah.
Okay. All right. One flew over the cuckoo's nest. Yeah.
Yeah. Ruined it for everybody.
Yeah, but I do think that. I mean, there are not a lot of psychiatrists around, but psychiatrists tend to have the expertise in this area. Unfortunately, there are very few psychiatrists who have the experience with kids with Down syndrome. I'm quite a rare beast. And I'm getting on a bit, I'm going to retire one of these days. But you'll probably find in every town there's probably one psychiatrist, or at least area. I shouldn't say every town. Each region will probably be a psychiatrist who might have some expertise in the area. You should just ask around and see who can help. I think it is helpful to have someone to hold your hand while you wait, or when you have questions around this. Yeah. I mean, if you're a little older, there's also in this province anyway, the developmental disability mental health teams that may be able to see your adolescent or adult with Downs. And then we also take referrals to our so-called neuropsychiatry clinic at BC Children's Hospital as well for kids with Downs who might have significant mental health issues.
Mm-hmm. One thing I want to just sort of unpick a little bit here. So let's say we try medication number 1 and it's not working well. Do we conclude based on that the other medications are likely to have the same side effects? I mean, I'm assuming no, because that's the whole point of having other medications is that they work in a slightly different way. So I think what can happen is parents write off medication because the first one is such a bad experience that they're like, well, this was terrible and that was sort of the best choice. So how is anything else going to be better or different? So can you speak to how that works a little bit?
Sure. Well, I think the first thing is if the medication doesn't work, you want to make sure it's the right class of medications. Like, are you treating? Like, I just think it's so important to ask your doctor and maybe be very clear what are the target symptoms that you're treating. Like I try to outline for ADHD. Okay, my target symptoms are going to be, I don't want my child to be touching all the kids and touching me all the time and talking all the time. And I want them to be able to sit in their desk. So just have some very clear target symptoms that you're focused on, because otherwise sometimes it's hard to know that is there a response or is there not a response. But yeah, I mean, you're right. The reason there are more than one medication is that, like even say ADHD in typical children, about 70% of typical children respond to ADHD meds based on Ritalin, but 30% don't. But the 30% who don't respond to the Ritalin-based ADHD med may respond to a dexedrine, which is based stimulant. And as I said, in special needs kids, sometimes I don't even use a stimulant. I would use a different class of medication called clonidine. So yeah, you don't want to give up too quickly. There are, different strokes for different folks.
Yeah.
No, that's a good way to put it. And I think what you're alluding to is the actual chemical compound is different. It's going to act on the body differently. And therefore, just because round 1 doesn't go to plan doesn't mean round 2 may not be more effective, or at least get you closer to that target that you're looking for, whether it's school attentiveness or aggression or whatever.
Well put.
Yeah. And would we be correct in assuming that, like, if a parent is hesitant about trying ADHD medication, I've had this conversation before, can we say that it's worth a try, but that there won't be any adverse side effects if we try it for 2 weeks and kind of wean the child off of it? Because that's, I think, another fear parents have is that I'll try it, but if it doesn't work, it's going to change permanently or for long-term change my child. Yeah.
Right. Yeah. Okay. Yeah. So I mean, parents have 3 main worries about medication. I learned this from Stan Kutcher, who's a psychiatrist in Halifax now. They worry, one is the medication going to have a long-term effect on the child. So the good news is stimulants. There are no long-term side effects. And if you stop the medication, you don't even have to wean it. You can just stop the medication. And it's out your body and there's no long-term risk. So, but that's the one question. The second question is, does it cause addiction? And these are kind of things actually that one should try and remember. I should try and remember to bring up with my patients every time I'm recommending medication. Most of these medications are not addictive, but it's important to maybe make that clear. And the third question is it going to change my child's personality? Which you already alluded to, usually in a negative way.
Yeah. I don't think anyone's mad if our child becomes cherubic and, never does anything naughty again.
Yeah, exactly. Yeah. Okay. No, that's good to know, because I think a lot of the times, and I've had experience with 2 clients where one, they've tried different trials and they finally found a cocktail or a a therapeutic dose that works for him. And then another client where it's like one and done, not going to work for us. We're going to just not try. And then of course you can't obviously push. But it's good to know these things because we're not psychiatrists, but at least we can impart this information on them.
Yes. Yeah. And do you want to talk about timing and dosage?
Yeah. So, I mean, you did refer to this a little bit earlier in terms of start low, go slow, I think is kind of the theme here. But how do things like, because I know with sleep medications and certain medications, they have a paradox effect or they will kick in at a certain time. Like, what are some of the considerations that parents should have when providing medication in terms of dosage and metabolism and how it interacts with their kids' chemistry?
Well, I think what you're referring to is that some children metabolize drugs faster than others. So in general, kids metabolize drugs faster than adults. So sometimes parents will say, gee, that seems a really high dose because that's like an adult dose. And it is. And that's because children metabolize medication so quickly that they often need adult doses. But there are some children who are what are called fast metabolizers. Because when you have a drug, it does its effect in the brain and then it gets broken down in the liver. It's like the factory of the brain and then disposed of. Well, some kids really metabolize that drug very quickly in the liver and it's gone. They actually need a higher dose than most kids. Other children, they metabolize really slowly. The drug stays in the body for ages, longer than it should. And so they need a lower dose than typical kids. One of the ways to find out is actually, this is often genetic. So check with the parents if they are someone who needs higher or lower doses of medications as a rule. That often guides you as to what the child will need.
Okay. That's really interesting. And so what I think you're saying there and what Hina's trying to point out is that there are some tweaks that can be done. You might have landed on the perfect medication, but we might need to tweak, and not me. You might need to tweak the dose or the timing or the frequency so that we're getting the positive impacts that we want at the time that we want them, which is, the school day or whatever. And we're not asleep or we're not totally wired after 2 hours. Like it was great and now it's gone kind of.
Yeah. So, I mean, the stimulant medications like Ritalin they've been around for many, many years. But one of the problems with Ritalin is, when I was starting out, is that it worked for 4 or 5 hours and then it kind of stopped working. And in fact, sometimes there was a rebound and the kid had even worse behavior when it wore off. So now there are these long-acting forms of Ritalin. So if you give a stimulant medication like Ritalin or Dexedrine, one should be able to give a once-a-day dose and it should last the whole day. But should is not what actually happens. So I just saw a kid yesterday who was on a medication called bifenton, which is a long-acting form of Ritalin. It's supposed to last 10 to 12 hours. Well, the medication wore off at 1 o'clock in the afternoon. And so she's probably a fast metabolizer, which I talked about earlier. And we had to actually change to a different form of Ritalin that was very long-acting, ultra long-acting.
Yeah.
So these tweaks can be made, though, is the idea that, and this is where parents come in to keep really close track. Like, it was working for this amount of time, and then this other thing happened, or it was working, and then my kid fell asleep, or, something else happened. But keeping close tabs on that helps you, I assume, to make these choices for what to do next. Do you often prescribe something like I would call it a drug trial diary? We do trial diaries for when I recommend things. Is that something that you often recommend?
Do you mean when we prescribe a medication, is it like is it like a trial?
I recommend, like, if I'm trialing an AAC device, something new for the family, I say, this is what we're looking for. A, C. Yeah. You tell me, you keep track. Is it happening on day 1? Is it happening on day 2? Do you do that as well?
Well, I should. I mean, I think that's the right way to do it. I mean, I think it's worth having a list of the target symptoms and then tracking on a daily basis or a weekly basis. Are they any different? And not just at home, but at school. I think it is the way it should be done. I sometimes do that. Like I'll give a rating scale to usually with the parents, I can get a good sense, and just seeing the kid, I can see if it's helping, but I want to know what they're like in another setting. So I often use those sort of rating scales to track the response with the school.
Yeah. And who you don't necessarily get to talk to. Yeah. I find it's helpful because parents don't necessarily remember or don't remember accurately what was happening a couple weeks ago. I don't make them do this forever. I'm not that mean, guys. But 2 weeks, we're going to keep track of it. And then we're going to see if we need to adjust it or whatever.
And I think it's important information for like that next visit with the doctor too, right? So that, because of course you're not seeing that kid on a daily basis. So for you, Dr. Friedlander, I'm assuming it will be very helpful to have that information to adjust medications the next time. Yeah.
Well, I mean, I think what I can tell you that often parents remember what happened yesterday, and I don't really kind of remember that far back. And I think what's sometimes helpful is to have some really hard indicators of response, like how many times has the child actually been aggressive? Like something like physical aggression. Let's be very clear. Has there been physical aggression so many times in the last month? Okay, now we're going to try this medication. Keep tracking the times the child has physical aggression, and we'll review that when I see you again. So they're very hard indicators. The what I gave you before are more subtle indicators. The other indicator is sometimes we use what's called a PRN medication, which is like something to give in an emergency. If the kid is really out of control and nothing's working. Well, how many times have you used the PRN in the last month? And then you give the medication. Okay, how many times have you given the PRN in the last month since he's been on the medication?
Yeah. I mean, and that's a really clear mechanism for a family. And also, then they get a sense of this progress too, which is important. I think, what's past is past. And a lot of parents forget, how bad it was compared to how it is now. Right. And that's fair and valid because it was probably a crisis.
Well, I think that's by the way, that's a really good point, Marla, is that we need to be really careful because often people come to see the doctor for medication after a severe crisis. And after the crisis, a lot of supports get parachuted in, lots is going on. The kid's put on medication, there's an improvement. It may not actually be the medication necessarily. There could be an argument for not prescribing the medication in the crisis, but waiting a month. So you're treating the baseline state, not the immediate consequence aftermath of the crisis.
Totally.
Yeah, kind of messes with the data that way in a sense, because you're not really sure exactly what the baseline is
where
first,
were you?
right? Where were you and where do you want to get back to? Yeah.
Dr. Friedlander, did you have any resources that you would like to share with the people who are listening? We can put links and materials in our episode page. Or is there anything that you think families should really be aware of going forwards?
Sure. I mean, I'm actually just trying to remember. I have got a UBC program, which you alluded to when you introduced me. So this is the UBC Department of Psychiatry homepage. And if you look under neurodevelopmental disorders, and you look under links,
Oh, great.
we put together all these
awesome
dual diagnosis resources, which are actually my Doug Lee, he's a psychologist who just retired. He'll put this together. We should acknowledge him.
Great.
And hang on, there's something else there is under links. There's also a link to healthcare access. Do you know these? It's Yona Lansky. She's in her group in Toronto.
Yes.
I think they do some really good work. It's on healthcare toolkits. I think they've got one for Down syndrome, checklists and so on. I think it's included in there. Okay, so that's quite useful, I think.
Yeah,
Fantastic.
Absolutely. We will put that information on our episode page so that everybody can find it really smoothly.
Good.
Thank you so much. Hinda, did you have anything else you wanted to ask?
Well, there's tons of things that I can ask for sure. I feel like we need to get Dr. Friedlander back again for another episode. But no, I think that you really provided us with a solid, not only us, but our listeners, our families, a solid knowledge base of how to really filter out Down syndrome and autism, anxiety. I definitely learned a lot today. And I think it's good because we can say these things about medication and treatment, but it's nice to get it from the source. So we really appreciate that. Yeah.
Absolutely.
Yeah.
Thank you for joining.
Yeah, sure. I mean, what you should probably do is, if we do this sort of thing again, maybe you should have one of the parents address this cold medication question from a parent point of view. So sometimes it's better hearing it from a parent than from a doctor.
Absolutely.
Yeah.
That's a great idea.
I'm into it. Let's do that.
All right. Well, nice to talk to you guys, and it's been a pleasure.
Thank you so much. We really appreciate it.